Hello and welcome to Series 3 of the Borne Podcast, the podcast that brings you stories of research, resilience and real-life experiences of pregnancy and preterm birth. I'm Ellie Gibson.
And I'm Caro Tasker.
And I'm Mark Johnson. As an obstetrician, I've seen the devastating effects of preterm birth, how challenging it can be for families who are going through that, and the extraordinary strength shown by parents. And I believe, because I'm a scientist, in the progress that can be made through research. And it is that belief that led me to found Borne in 2013, to better understand pregnancy, to find ways to prevent preterm birth before it begins.
At Borne, our aim is to prevent preterm birth, giving every baby the best possible start in life. We fund pioneering research to deepen our understanding of pregnancy and childbirth, research that brings us closer to answers and realising our aim to prevent preterm birth.
In this podcast, we bring together parents, experts and scientists to share their stories with honesty and compassion. We talk about the science, but we also talk about hope, heartbreak, courage and the small victories that mean everything. Because every insight, every conversation and every breakthrough moves us towards a future where more babies can arrive safely at the right time. So on today's episode, we are putting Mark in the hot seat. Yes, Mark, don't look at me like that. It's all going to be fine. We're going to give you some hot potatoes in the hot. Everything's hot, basically. Caro and I are perimenopausal, so we're hot anyway. We want you to be the same temperature as us by piling you with hot potatoes. Is that all right?
I'm looking forward to it.
Good. Mm-hmm. That sounded almost sincere. So in all seriousness, these are the questions that we've had sent in to us from listeners and that probably you get asked quite a lot, Mark.
Yeah.
But for people listening to the podcast who don't have direct access to you, we thought this is a good opportunity, isn't it, to quiz you, didn't we, Caro?
We did. And we're going to start with one. And she says, I wish I'd known more about what can happen when it can go wrong, but it's hard to find out without terrifying yourself. What are the signs to look out for when it comes to premature birth? Which I know is an enormous question and a very difficult one to pin down and answer, but what would you say are you looking for in terms of if there is a top 3, top 4, top 5? What are the most important things?
I mean, I think to address the first question is it's hard to be educated about what can go wrong. And I remember when I was having my first child, I just assumed everything was going to be fine, even though obviously as an obstetrician, I knew that problems could occur. And I think it's very hard when you're seeing first-time parents particularly to really give them the information without almost bursting their bubble of assumption that everything's going to be fine. But it is important to be informed because unless you're informed, you will not know what's going on. And I think the top things, you talk about preterm birth. Firstly, premature birth is both spontaneous, in other words, it happens almost out of the blue, and it happens because I feel as a doctor that your baby is better to be born now, either for the baby's sake or perhaps for the mother's sake. So in terms of, let's deal with that first group initially. So in the mother's case, it's usually related to preeclampsia, high blood pressure, protein in the urine, problems that could affect the liver, the kidney, can affect the blood. And sometimes this can be life-threatening, and it is still one of the major causes of death for mothers in the UK today. So when we see somebody with a severe case of preeclampsia, we will often choose to deliver the baby early. What would you know if you were going to develop preeclampsia? Well, you might notice swelling, quite dramatic swelling, coming on quite quickly.
Whereabouts? Would that be all over? Or?
It can be all over, and people notice, typically they say, my face has suddenly changed. And it's their husband or their partner who's noticed that their face has suddenly changed. It's become puffier. You may have headaches, you may have flashing lights. These are really quite close to the end stage. Now we have screening tests and we can pick up people who are at higher risk of having preeclampsia, for example. So often you will have been told you're at risk of preeclampsia. I hope one day that all women will be screened at 12 weeks of pregnancy to look and see whether they are high risk for preeclampsia. Because once we've identified it, if we give aspirin, we can reduce that risk by 93% if people take it absolutely every single day.
And is that something, can you ask to be screened for preeclampsia on the NHS? Or?
So not even privately, not all ultrasound, it's an ultrasound scan. It looks at the blood flow to the womb. It measures the the levels of placental hormones in your blood, and it measures your blood pressure. And they take those 3 factors and they put them all together and say you are higher or lower risk of preeclampsia. And then you can be given aspirin if you are high risk. It is not widespread. There's a big study, it's just starting, called Starship, to see what the benefit of that is. I mean, to me, I think it's a no-brainer that if we can screen and detect a high-risk population and that we intervene and we know we can reduce preeclampsia, it's not simply that preeclampsia is going to cause early birth. It is that it actually causes a long-term impact on the woman so that you're 4 times more likely to have cardiovascular disease in later life. So preventing preeclampsia is yes for the pregnancy, yes for the child not to be born preterm, but also because it's better for the mother's long-term health.
Why isn't it just a standard thing?
It's a really, really good question. So we have had studies which have shown that it is effective, but those studies have been done by highly specialised centres. And the National Screening Committee feel that for a test to be applied across the whole of the NHS, we have to look at it practically, like if a hospital in Derby, for example, is doing it, as opposed to a centre of excellence where everybody is trained within an inch of their lives so that they can do the scan perfectly time and time again. If we're going to use that screening test in somewhere which is part of a normal antenatal care, does that work? Does it actually result in a reduction in risk? And that information is not there yet. So this study, Starship, is hopefully going to give us the information that when it's applied across the piece, across lots of different hospitals, that we will show benefit. I'm confident that it will. The next thing that you may find, the next cause of preterm birth that I may say to a woman, you need to have your baby early, is when the baby's not growing so well. And how would you notice it? Well, honestly, truly, you probably wouldn't notice it. And who's at risk of it? Well, if you're underweight, then you are at higher risk of having a smaller baby. If you smoke, you're at higher risk of having a smaller baby. If you've had a small baby before, you again are at higher risk. And there are a whole list of other at-risk people. And then those people, we will then plan to screen their baby's growth. So we can do an ultrasound scan at 28, 32 and 36 weeks, looking to pick up when the baby's not growing so well. So those are the 2 sort of reasons that I might say to you, you need to have your baby early. Now, the third group, spontaneous onset of labour. Again, there is a screen test coming through that is being trialled as we speak, looking at the length of the cervix at 20 weeks. And those people with a shorter cervix are at higher risk of preterm birth. And again, we can give progesterone, which will reduce the risk of preterm birth. And if we know you're at risk of preterm birth, we can monitor you and we can tell you the signs to look out for. What sort of signs would I pick up on? A change in vaginal discharge. A watery discharge may mean the waters are going. More slight bleeding may suggest that the cervix is opening. These are the things that I would ask you to come and talk to us about. Urinary tract infection is associated with preterm birth, so pain passing urine. Feeling more frequent Braxton Hicks. And sometimes they masquerade. You think, what's this funny pain that's coming and coming? It's coming more frequently and getting stronger. You really need to get in to be checked by the hospital.
Yeah, I thought I was having Braxton Hicks, and then my friend who's known me all my life and who's also a health visitor and a nurse, she knew in my voice and she sent me to hospital, and she was absolutely right, because it turned out, no, this is the real banana. Similar to that. So I've got a friend who's just become pregnant after an IVF journey. So it's, there's a bit of tension and stuff there anyway. Yep. And she's kind of thinking, what are the best things I can do to prevent premature birth, or at least to look after myself, to give myself the best chance? Because as we know, the advice seems to change. Even between my 2 pregnancies, I could eat smoked salmon for one, and then I couldn't, which I know it's just people doing their best, right? But what's the latest, Mark? What's the latest best advice we have for pregnant women now?
Well, I mean, it starts before you get pregnant, as you might guess. And we all know about folic acid. I always try and persuade people to eat a lot of fish, wild fish, not farm fish, of course, because it gives you lots of trace elements and will give you all the DHA, which is a sort of a fatty acid, which is essential, which is anti-inflammatory. And I believe that inflammation is actually at the root of a lot of the problems that happen during pregnancy.
Well, you're doing a whole study into that at the moment,
yeah. We're looking at people in India who have a very high rate of preterm birth, and we're choosing those people who have low levels of DHA, and then we're supplementing one group with high levels, and we're giving just a little bit, which is the current recommendation of 200 milligrams of DHA a day, to the other group. And then we'll see what the benefit is of actually giving a lot more DHA, both in terms of preterm birth, but also in terms of the mother's brain, mental health, in terms of baby brain growth. So DHA is essential for the way brains function.
And you need to eat wild fish, that you can't get it in a pill or a...
You can. So funnily enough, algae make DHA. Krill eat the algae.
Here we go. He's in the pocket of big krill. I'm telling you.
I know. I am indeed. I mean, I think, and then fish eat the krill, and then we eat the fish. So it's really third-hand DHA made by algae, eaten by krill, then eaten by fish, and we get to eat it. Well, it's fourth-hand, actually, isn't it? So you can get algal DHA, and yeah, that's fine. But a lot of vegetarians, for example, will eat some sorts of grain which have high levels of the precursor for DHA. But the problem for us humans is that we can't make DHA from that precursor. So as a vegetarian, you can eat algal DHA, and it's much better to get DHA rather than the precursors. So pre-pregnancy, folic acid, DHA, keep yourself fit. And being physically fit will reduce your risk of being depressed during pregnancy, reduce your risk of preeclampsia, gestational diabetes, and if you want a vaginal birth, it reduces your risk of emergency cesarean section during your labour. So to me, keeping fit, well, what's not to like? Those are the key things that I say to people. Be mentally well before you get pregnant. Having poor mental health before you get pregnant increases your risk of complications, increases your risk of preterm birth. And actually get help if you are unwell. If you have mental health problems, get help during pregnancy, because if we can improve your mental health state, that will reduce your risk of preterm birth.
So what is the relationship between mental health and is it anxiety is like more likely to bring on labour, or?
It's a very good question. We don't understand that. It's not preterm labour, it's actually baby growth. So it leads to poor fetal growth. Now, why might it do that? We know with depression you have higher levels of inflammation. When you have higher levels of inflammation, I don't think the placenta works as well. So I think tackling the mental health problem will reduce your inflammation, will help the placenta work better.
Chronic stress, for example, stress that lasts a long time.
Yes.
That produces high levels of cortisol.
Yeah.
So explain that then. If the cortisol is beneficial in terms of steroids, what is it in terms of, how is it not benefiting when we are, obviously, our cortisol goes through the roof if we have chronic stress and anxiety, and mental health is an enormous part of maternal health.
Yeah, absolutely.
So
I mean, it's a growing problem.
Yeah, it's a growing problem.
Yeah. So how does that all work together? So cortisol in our blood, human blood, it doesn't cross the blood, it doesn't cross the placenta. The placenta's got an enzyme there which will chew up the cortisol. So the baby's protected from stress levels of cortisone. So when we give steroids to help babies' lungs mature, we have to give a synthetic form of steroid which will cross the placenta. It doesn't get metabolized by this enzyme. So we give dexamethasone or betamethasone, which actually bypasses that enzyme. Interestingly, if you eat a lot of licorice, you inhibit that enzyme and you get more cortisol going to your child, and that has an impact on neurodevelopment, an adverse impact on neurodevelopment. So when anybody says I fancy a bit of licorice, I say please don't eat licorice during pregnancy.
That's extraordinary.
Amazing.
That's extraordinary. But I'm delighted to hear it because it's disgusting.
Disgusting.
It's disgusting. Absolutely revolting. There was one question that came up that actually affects our family. In terms of neurodivergence and cognitive differences within children. So we had a question relating to preterm birth in terms of autism and ADHD.
Yeah.
Now, obviously, I'm impacted by that myself. I have a child who is autistic, and she was born prematurely. However, there is also a genetic link. So could you explain a little bit more about how neurodiversity is involved within preterm birth?
Yeah, I mean, I can try. Clearly, we do not understand.
It's an enormous subject, so we're literally touching the surface.
I think we discussed earlier the fact that it is a spectrum. There are lots of different types of neurodiversity and requiring different treatments and different approaches, and finding the right almost diagnosis is key to getting it right in terms of treatment. In terms of preterm birth, we know two ways in which that could increase the risk of autism. One is that it's in the last trimester that you get the transfer of the fatty acids which are essential for your brain. As you know, your brain is 60% fat. and that of those fats, about 15% is DHA and about 10% is another fatty acid called arachidonic acid. Those fatty acids cross the placenta predominantly in the last trimester after 28 weeks. Preterm birth, if you're born before that time or during that time, means the brain may not get as much of those building blocks which are essential for putting together your brain in a healthy way. The other thing that happens in preterm birth is inflammation, which we've already talked about. And that can have an impact on the way the brain develops. So if you look at these large studies coming out of Scandinavia, you see more types of neural development in mothers who've had antibiotics during their pregnancies, implying that if a mother has an infection, that inflammation then impacts on neurodevelopment. So I think both of those could have an element of explanation as to why we see these problems more frequently in babies who are born preterm.
Because, my son, who was born early, has just recently been diagnosed with autism, which nobody is shocked by, including him. Although now he says things like, can I have a day off school because I'm autistic? And we have to say, no, you can't. But it has sort of brought up some old feelings for me about, is this, my fault because I had him early, and is this? But then again, his little cousin has also been diagnosed with it, and he was born right on time, and it feels very sort of confusing, the stuff that's out there.
I mean, there are genetic elements to this, so you see families who have a lot of autism in the family. But interesting, there was a paper where, again, giving DHA to people who had one child with a diagnosis of autism reduced the risk by 40% if you took DHA or ate a lot of fish, reduced the chance of you having a second child with autism. So I think there is some element of environment. Maybe that's because the DHA represses inflammation. Maybe it's because it helps the brain develop. But there is the underlying genetic factor, which you are not going to change. And part of the fact that we're seeing more autism, I think maybe we're more aware to some degree. But if you look now, I think the latest data out of Scotland is 1 in 20 or 5% of children are now diagnosed to be on the spectrum. And that does seem to be becoming more common. If you look at mental health, again, the rates are escalating and at an unbelievable rate. And why is this? I don't think we really understand why, but how we make brains, I think, is key to that. And as you know, I always talk about DHA, but again, we found that in mothers who are depressed or anxious during pregnancy, they have low levels of DHA in their blood. If you give DHA with EPA, you can treat maternal depression with that. If you look at a lot of mental health problems, again, optimizing your DHA intake has a beneficial impact on that. So I think there's lots of reasons for these problems, one of which may be our nutrition.
Education within school and should start within school. It should be included within the curriculum at school, maternal and fetal health for everyone, because that knowledge is going to have a direct impact on the vast majority of the pupils there, whether they may choose not to have children, of course, and that's completely their choice. But a lot of people will go on to have children, so it directly will impact all of them in that way. So, I mean, that's something obviously you agree with. How do we start that? How do we change that? What sort of education, where do we start with it?
It's a really, really good question. So I've been talking to the chairman of school governors of a girls' school. 50% of pregnancies are unplanned. So unless we...
50% of pregnancies are unplanned? Really?
So unless we improve the health of the population, we are not going to actually have a major impact on the problems we experience. And I believe that starts in schools. And I believe it starts with actually building mental resilience in schools. We hear a lot about providing CAMS and the support to children who have mental health problems. We don't do anything to try and promote good mental health. How do we actually build resilience? How do we help children become stronger before they experience these problems? How do we persuade children of the importance of diet and exercise? And as an obstetrician, I know I can try and persuade a pregnant woman, stop smoking, try not to put on too much weight.
I can try and persuade a teenager not to eat 6 packs of Quavers a day. I can try all day, Mark.
Well, we did this study. I mean, we were talking with Professor Poston, and actually she did this study when they had one-arm intervention group in people who had a raised BMI, and the difference between the group that they were trying to get to not put on weight as much as the other group was 1 gram. And it really tells you that we cannot change people's behaviors when they're adults. So if we actually hope to make an impact on population health, it's going to have to start in schools. And that's what we're working on in Chelsea and Westminster with the help of our hospital charity, CW+, to actually think about how we can go into schools, promote resilience, promote mental strength. And I think that's really, really important.
And there's been this massive boom in these weight loss drugs.
Oh, yeah.
What's the advice around those and getting pregnant, being pregnant, and the impact?
Yeah. So at the moment, we really don't know enough about the GLP-1 agonists. And the advice is as soon as you know you're pregnant, stop them. In an ideal world, you would stop them 3 months beforehand to make sure they're out of your system.
It's just the not knowing. It's like you were saying, 50%. It's the people that don't know.
Exactly. So, but weight loss does help you get pregnant. So, maybe they are a way to help people have a more regular cycle, for example. So at the moment, I'm afraid it's an unknown. Maybe in time we will know that they are safe enough during pregnancy, but we don't know that yet. So please stop them when you're planning pregnancy or as soon as you know when you're pregnant.
Stop the Ozempic, inject yourself with krill, off you go.
And start the krill and the folic acid, of course.
So we have had a question mark, which I know can be a little bit, it's a little polarising.
It's a hot potato with a can of worms on top.
It's the whole breastfeeding versus bottle feeding, but I am asking it in the context of preterm birth. No one's judging anyone.
It's a very good question. We like breast milk compared to formula milk. Why? Because breast milk contains all kinds of things which we really don't understand. For example, we were talking about this 20-hydroxysterol that will help you repair your brain as a preterm birth. It'll make the nerve cells differentiate. We don't know how important that is. We don't know how much of that is in cow's milk. We've only just discovered this. So there are elements in breast milk which we think will help your baby, premature baby particularly. A mother's breast milk changes if the baby's premature. A mother's breast milk changes if you've got a boy or a girl. So clearly this is almost
How does it change?
I don't know how you can change, but there seems to be some two-way conversation.
The components of it change, the constituent ingredients change.
Exactly.
I didn't know that. Did you know that?
I didn't know that either.
So
I did not know that. It's the most extraordinary thing, I think.
It is. So, but equally, try as hard as you might, you may not be able to breastfeed. You may not have any breast milk, no matter what you do, no matter how hard you try. And yes, and for preterm babes, there are breast milk banks. So you can get breast milk for your preterm babe. And people donate to that. And I think it's really important. So if your hospital has a breast milk bank, I would encourage you to donate to that breast milk bank because it makes a big difference to preterm babes.
Or I think sometimes maybe you need to give formula because of other things going on. So with both neither of my children slept. The one that was on time and the premature one, he was particularly bad, but they were awake. At one point, Joe used to wake up every hour and I was just going nuts. I just couldn't cope and he was really hungry. And so we ended up doing a thing where I was breastfeeding, but I would go to bed at sort of 7, 8 o'clock at night. And then Pete would give him formula if he woke up until about midnight. And then Pete would go to bed. He would sleep till about 6. And I would sort of breastfeed. And then Pete would go to work. And I would somehow try to get on with my day. But that, for us, was giving the baby formula as well as breast milk was about survival in terms of my mental health and just being able to look after the other child and get through the day. And I don't feel bad about that, to be honest.
Well, nor should you.
No. And I think even if you can't even do that combo thing, if you just have to do formula for whatever reason, then I think it's going to be okay, right?
It is, absolutely. You can't tell the difference between a breastfed baby and a bottle-fed baby as they're walking down the street, can you?
No, it's not like mine have got one ear bigger than the other.
Well, precisely. Do you know what I mean? No, I mean there are some circumstances when babies are very small when they come out, when they're at risk of low blood sugar. And obviously when you first give birth, you've only got a very small amount of colostrum. And babies need energy. They need sugar at that point to keep their blood sugars up. Otherwise, they'll be given a drip because their blood sugar is too low. Similarly, they may get very jaundiced, and they need the fluid to help them deal with the level of jaundice bilirubin in their blood. We will be saying, please do give your baby formula milk because it's essential, and your baby will not do as well if you don't. So there are circumstances when clearly formula is essential. And as I say, with the best will in the world, not all of us can breastfeed, and you can try, but please don't beat yourself up if it doesn't work for you, because you have tried.
Another sort of hot topic we hear a lot about these days is the microbiome, right? And all the bacteria the good bacteria that the baby gets and needs. Yeah. And I remember in the sort of post-birth sort of premature sort of horror show, one of the rabbit holes I went down was I read that with vaginal birth, your baby gets covered in all this amazing muck, which means it will never, get ill or something, and always have regular bowel movements. Yeah. Whereas, and if you have a cesarean like I had, your baby's going to miss out on all this, all these amazing germs, and therefore you've totally failed it. Yeah. And as a mother, and you should just get in the bin. Now, I've managed to climb out of that rabbit hole some 11 years later, but it was a pretty dark place to be in. I mean, how true is that?
So the microbiome. So if you imagine the vaginal microbiome, we don't know what is a good vaginal microbiome. We don't know whether or not your microbiome is one that one would want, if you see what I mean.
I think mine's pretty special.
I am sure your vaginal microbiome is super special. But
thanks, that's the nicest thing anyone's ever said to me.
But for example, 15% of the population carry group B strep in their vaginas.
Oh, right.
If you as a newborn baby catch group B strep, it is potentially fatal. So clearly there are circumstances when having your mother's vaginal microbiome may not be good for you. We need to understand what is a good microbiome, and then we need to understand how we can give your baby that optimal microbiome. Yes, vaginal birth will give you the microbiome. If you are having a cesarean, I would recommend you did a group B strep test first to make sure that you don't carry group B strep, but you can then put a swab in your vagina before you have the cesarean section and wipe that swab on your baby. And data show that you actually will give your baby your vaginal microbiome by doing that. But
are the doctors going to look at you funny if you start asking them to pop a cotton bud in there?
We give you the swabs and we ask you to do it for yourselves. Actually.
Right. But that's something you can ask for, and you're not going to get just shot down.
Not at all. I mean, there is good evidence that obviously having a good microbiome is healthier for you. But what constitutes a good microbiome, I still don't think we're clear about.
Not all vaginas are equal.
We have always get questions on the sickness in pregnancy, why it's called morning sickness when, frankly, it can last all day. And for example, in my case, it was far worse with my daughter than it was with the boys. And I'm just going to add a little side order on that, in that with my first pregnancy, I got an incredible amount of saliva, like a huge increase in saliva, which tasted of rusty coins.
Yeah, metallic.
Like metallic. And that, in turn, increased my morning sickness.
What's that?
Yeah, what the hell is that?
Well, let's deal with the metallic. That's supposed to be estrogen in your saliva.
It tastes of metal.
And it tastes of metal, and you see these poor people who have to spit it out because it tastes so bad you can't swallow it, which is why you feel I've got loads more saliva, because you would naturally swallow it, but you just feel you can't.
Oh, so you can't swallow it and not be sick. It's horrific.
It's the flavour of the saliva rather
it really
than
is
the
very metallic, and it's awful. But morning sickness in general obviously doesn't just last in the morning. It can go on all day.
Morning sickness all day.
And it also, is it worse when you're pregnant with females over males?
So it is said, but equally I know a lot of people who come to see me and they've had a girl the first time and then they're far sicker with the second time. Now, we know that probably the best thing for morning sickness is rest. So if you've got one child and you're trying to rest when you've got one child, as you both know, it's not possible to rest as much in the second pregnancy as it was in the first pregnancy, because when you didn't have another child, you could go and put your feet up and have a rest at any time of day if you're not working, of course. We used to say it was due to HCG, and we used to say that it was because the variation was because of the acidity of the HCG. So you got more acidic forms, less acidic forms. The more acidic forms, typically you would see in South Asian women, made one feel more sick. Now we know that there's another factor called GDF-15, or Now we know that the factor is GDF15, which is produced by the fetus, and it is in fact that which makes one feel sick.
That's new information.
It is new information. I think it was 2023.
Very new information.
Well, this is hot off the press.
That's what you were saying.
I had some even newer information this morning. I wanted to ask you about it. I heard on the radio this morning, I think it was Women's Hour, they were saying that if you had postnatal depression, you are more likely, they think, to have depression in menopause or to find perimenopause difficult to struggle with mental health around that time. So that's a good indicator.
We are very susceptible to our hormones, males as well as females. So I would have thought if you're postnatally, you're feeling depressed, you haven't got any hormones in your system, breastfeeding turns off your ovaries, you don't produce estrogen or progesterone. Similarly, menopausally, you don't have estrogen and progesterone in the system. It may be that simplistic, or it may be totally simplistic, and there are people probably listening to this thinking, oh my God, he's so ignorant, he doesn't know what he's talking about. In this instance, I would say I don't know what I'm talking about, but that may be the link.
I might apply to do a study. I might send the form in to Lucilla and say, right, let's get on it.
Let's do that.
Now, this potato is steaming hot, Mark. We've been asked a lot of questions about the use of the term natural childbirth, because a lot of people, I'm going to say including me, who had to have a medical intervention. In my case, it was a caesarean, and actually even with the child that was on time, we had the tongs.
Forceps, yes.
That's whatever.
Yeah.
And I have felt a sort of annoyance when I've heard people talk about natural childbirth, because the implication, therefore, is that my birth was unnatural. And unnatural is a word we sort of associate with bad, terrible things, murderers and so on. So I don't personally like the term natural, but is it, maybe I should just get over that? Is it just a natural scientific term?
I don't think it's a scientific term, and no, I wouldn't get over it. I mean, the miracle is that you have been pregnant. You've been pregnant for 9 months. How you eventually give birth is, to me, completely immaterial. I find it quite upsetting, and I feel really sorry for some people. They come in and say, I want to have everything natural. And then when they don't, they feel somehow they failed. But obviously, your success is having a lovely, healthy baby, no matter how you achieve that. So I don't actually talk about natural birth personally. I talk about having a baby and what is the safest and the least traumatic way for you as a woman to have your baby. And that may be with induction, that may be through a cesarean, and it may be when you've been pushing for a while and the baby has not arrived. It may be that we do need to use a ventouse or a pair of forceps to help you.
Or for some women, in terms of trauma, it might be that they have as least medical intervention as possible because they find it traumatic for whatever reason to have medical intervention.
No, absolutely, completely. And some people are lucky. They can literally have the baby on the bathroom mat. But I'm afraid that's not true for a lot of people now. As we wait longer to have our babies, and this is a societal problem, we wait longer to have our babies. Perhaps we're a little bit more overweight when we have our babies. We're less physically active. All those things mean that we're more likely to have a difficult birth. It's less likely that you will have a straightforward, easy vaginal birth if you're 40, if your weight is slightly higher. And so, I think we have to accept that these are facts, and just say, look, the miracle is I'm pregnant and I've had a lovely child.
Yeah. No one talks about I had a natural appendectomy. Yeah. I just got a penknife and I just
natural
quickly
heart attack. Exactly.
in there.
The other press out there is inductions are bad and they should be avoided at all costs. Well, the data show that if you have your baby before 40 weeks, you're much more likely to have a vaginal birth if that's what you want to have. And it's, we presume the baby's going to be smaller. And it is that simplistic. If you have a smaller baby, it's going to be easier for you to actually deliver your baby vaginally. And if you wait till your baby's much larger, it's going to be more difficult. And the longer you go past dates, then the more your placenta has aged, so it's less able to tolerate the stress of labor. If you think about it, each time you get a contraction, you cut the blood supply to the placenta. As your placenta ages, it's less able to continue to supply oxygen to the babe. So having your baby before 40 weeks reduces your cesarean section, probably because A, your baby's smaller, but B, your placenta is healthier and actually can support the pregnancy, support your baby better through that vaginal birth. And I believe that there will come a point when we will understand that we should have our babies before 40 weeks because it will be safer for our babies, safer for the mothers.
That knowledge is very important. I think it's quite empowering, actually, because I think there is then an argument to say that you could go to your gynaecologist, your healthcare provider, your midwife, and say, listen, I know that this is a fact, this is a scientific fact, and I'm uncomfortable to go past 40 weeks. And how do you propose we address that?
Well, the question for the lady who had IVF, we would recommend that you have your baby by 40 weeks. But if you've had IVF, but there's so much press out there pushing this concept of everything should be natural. Everything should be safe. That is the key. You want to have a happy, healthy baby. That's why you're pregnant. It is not to have a vaginal birth.
And we've got new technology. We've got we used to cauterise wounds. We don't have to do that anymore. No. Like, I've got a metal plate in my knee. We're living in the future.
Yeah. I remember I had my great-great-grandfather, who was Queen Victoria's gynaecologist.
What? Wait! Just drop that in. Just drop in that humble brag.
Oh my
cheeky name God! Say that again.
This is all about technology.
No, hang on, no.
It isn't.
Your great-great-grandfather was Queen Victoria's gynaecologist.
You're a Nepo baby.
Indeed.
Didn't she have 8 children?
I think she had a few, but he was the gynaecologist, so he only dealt with her after you had the babies. He wasn't the obstetrician, remember?
Wow.
But the point I was going to make is that back in the day, you have, I don't know if you've ever heard of this condition called a cervical ectropion. It means that the cells on the inside of the cervix grow onto the surface and you get a much more marked vaginal discharge and you get quite a lot of bleeding. And so back in the day, they used to take a hot coal and a pair of tongs and touch it to the cervix. And you can imagine that would cause some degree of pain.
Do you think?
Yeah.
Do you?
So my great-great-grandfather, given me enough greats, designed this cylindrical tube where you could visualize the cervix and pass the hot coal up there without burning the walls of the vagina on the way up.
What was his name?
He was called Ferguson, William Ferguson, Sir William Ferguson.
Sir William Ferguson.
He was something of a dandy, actually, I was told. If you read about him, he used to drive around with 2 men on the back of his coach and horses, and the coach was a mustard colour.
Of course it was.
And they used to call it his students used to call it the mustard pot.
Wow. And just inserting toilet rolls and hot coals into women. That's amazing.
Yeah, but to help women.
Yeah. But you see, not using the technology, why would you not? If you had this problem, why would you not use this technology? Why would you not avail yourself of the technology? That's the point. If we can help you have a happier, safer birth, why would you not want to do that?
Yeah. And is that part of the reason you got into this?
Well, my mum's a midwife, actually.
Your mum was a midwife, but you knew growing up about
William Ferguson.
Oh, yeah.
Sir William Ferguson.
Wow.
Yeah.
Have you got a mustard coach?
Sadly not.
Why not?
I have a black smart car.
It's what he would have wanted. Get yourself a mustard Kia at the very least.
And he had 2 Dalmatians which ran along at the front as well.
We need to get him on the podcast somehow.
I don't think anyone will listen to any more information. I think they just want to know about Sir William Ferguson and his mustard coach. That's phenomenal.
Go and Google him.
Yeah, it is phenomenal. I think essentially what you and what all of your colleagues and teams are doing we have to make it better.
We do.
We have to make maternal and fetal health better. At the forefront of that is research that we are doing, that Borne are doing to make this better.
Absolutely.
Well, thank you, Mark. Thank you. What were the Dalmatians called, by the way?
I have no idea.
We must find out.
I feel like we need to find that out. That's phenomenal.
That's phenomenal. Thank you so much for answering our hot potatoes, or hot coals, as we'll call them next time.
Absolutely. For more information on the work of the Borne Foundation and how you can help the charity save babies' lives, please visit www.borne.org.uk or follow the links in the podcast notes. The Borne Podcast is presented by Ellie Gibson, Caro Tasker and Professor Mark Johnson. The music is by Kirsty Newton and it is produced by Laura Grimshaw.